once again, ladies and gentlemen. Our discussion here will be on cholinergic agonists, and this continues our discussion on the autonomic nervous system. USMLE Step 1 really likes to test this, and they really like to test the autonomic nervous system in general. And cholinergic agonists and antagonists, as well as your adrenergic agonists and antagonists, these pharmacologic agents are a great way to to test both pharmacology and to test physiology. And you can often do this in the context of pathophysiology. So you can imagine the USMLE really likes this system. Now, as for Step 2 and Step 3, you really want to be paying attention to some of the practical applications of these agents. And primarily, as far as practicality, there's not as much as there used to be, but you still see some practical applications for ophthalmologic purposes, so inducing meiosis and reducing intraocular pressure. And you do see a few of these medications given for myasthenia gravis and a few of them given for the symptomatic treatment of Alzheimer's, which we're going to be talking about here. If you haven't already, please consider subscribing to my Patreon page at www.patreon.com/pwbmd. You can click the link below in the description of the video or on the I button on the upper right hand corner of your screen, and it should link you up. If you consider chipping in $1 a month, a little bit goes a long way to help keep these videos free. If you subscribe, you'll have access to some of my premium videos in which I go over case reviews, formulating a differential diagnosis and treatment plan, and that should help you as you gear up to study for Step 3 of the USMLE and for clinical practice, because real life is not a multiple choice test. So thank you very much in advance for your patronage. So just an idea of what we're going to talk about. We're going to briefly talk about muscarinic receptors. I talked about this in greater detail in the autonomic nervous system talk, but it is worth just recapping what these are because they play a very important role in cholinergic activity. We'll talk about two different classes of cholinergic agonists, direct acting and indirect acting. Indirect acting can be further broken down into the reversible indirect acting and then one particular drug which is irreversible indirect acting. We'll talk about a very important application of cholinergic agonists, and that's cholinergic agonists that are due to organophosphate poisoning. Organophosphate is a particular pharmacologic type of cholinergic agonists. They're used for pesticides, but they're also used in chemical terrorism. And so it is worth talking about because it does come up on USMLE, especially Step 1. We'll talk about the antidote to organophosphate poisoning, that being pralidoxime, and then we will do a quick recap. So these are your different pathways in the autonomic nervous system. Here in the blue you have parasympathetic, in the red you have sympathetic. The motor neuron, this is a lower motor neuron terminating in a neuromuscular nicotinic receptor, NM. And this is not part of the autonomic nervous system, but when we're talking about the autonomic nervous system, there are two really important types of, well, really three different important types of receptors. You have nicotinic receptors, and in the autonomic nervous system, those are NG, or also referred to as NN receptors, and that just means neuronal nicotinic or ganglionic nicotinic receptors, and these are at the ganglia. In the somatic nervous system, where we have your motor neurons, you do also have nicotinic receptors there, but those are muscular nicotinic receptors, and they sit at the skeletal muscle. This is not part of your autonomic nervous system, though. So for our purposes here, it's not going to be important. But when we talk about cholinergic antagonists, it will come up with some importance, even though that does not affect our autonomic nervous system. So there are some drugs that work on the NG receptors or N receptors, and those drugs, for our purposes, are not super important because they either knock out or they stimulate both the parasympathetic and sympathetic nervous system, so their effect is really a wash. If you do go and read up on these, which I do recommend, it's not going to be in our talk here because they're not agonists, they're antagonists. Mecamylamine and trimethophan, what they have the effect of doing is that they wipe out both the parasympathetic and sympathetic response, so you don't have any autonomic response. And so that can cause physiologic problems, but we don't prescribe these drugs. So if you're taking step one, you should read up on these, but we're not going to talk about them here. I will give them a little bit of treatment when we talk about the antagonists of the cholinergic receptors. So here you can see, aside from the nicotinic receptors, there's two other very important receptors, your muscarinic receptors. Muscarinic receptors are going to predominate on the parasympathetic division of the autonomic nervous system. You can see that the target organs are full of muscarinic receptors in the parasympathetic tracts. So SAAV nodes, GI smooth muscle, bronchioles, eye muscles. If you really think about it, anything that the parasympathetic nervous system does, your muscarinic receptors are going to take care of. Now, in the sympathetic nervous system, we also have muscarinic receptors, but they pretty much only exist on sweat glands. So if you have stimulation of your muscarinic receptors, which is exactly what cholinergic agonists do, you're going to have all these things that we typically associate with the parasympathetic nervous system. So contractility of the GI muscles. You have bronchial constriction. You have meiosis. All of those things we associate with parasympathetic response, and you're going to get a lot of that in cholinergic agony. The other thing that you will see, and especially when we talk about organophosphate poisoning, is sweating. And even though sweating is not part of a parasympathetic response, it is part of a general muscarinic response, even though this is mediated by the sympathetic nervous system. And so we'll see that sweating, diaphoresis, is a symptom of cholinergic agony, of organophosphate poisoning. What we don't see with cholinergic agonists is anything mediated by these adrenergic receptors. And this is your sympathetic response here. All right, so for more on this, you can go back to the autonomic nervous system talk. So our muscarinic acetylcholine receptors, remember that nicotinic and muscarinic receptors respond to acetylcholine, which sets it apart from the adrenergic receptors. These exist on various effector organs in the CNS, and this mediates parasympathetic activity, the only exception being the muscarinic receptors that sit on your sweat glands. That's going to be mediated by the sympathetic nervous system, but all the same, it responds to acetylcholine, and therefore it is going to be agonized by cholinergic agonists. You're going to have more activity at the muscarinic receptors. So your M1 muscarinic receptors are primarily on exocrine glands. So this is how, when your parasympathetic nervous system kicks in, you start salivating, you start making gastric acid. The M2 muscarinic receptors are on your heart. This will slow your heart down. And the M3 muscarinic receptors are on smooth muscle. This causes bronchoconstriction. They're on your bladder. It helps you pee. It's on your vasculature, which causes vasodilation. It's on the sphincter pupillae muscle, which when stimulated causes meiosis, causes the pupil to contract. And then it's on the ciliary muscle. Remember, the ciliary muscle helps you with accommodation. It changes the shape of the lens. And it's on the pancreas, which helps with insulin secretion. As mentioned, the transmitter for the muscarinic receptor is acetylcholine. So the effects of cholinergic stimulation, it's good to just know these, because when we're talking about organophosphate poisoning, when we're talking about why these drugs, if at all, why these drugs are useful, what kind of toxicity or side effects you can get from these, it helps to know what happens when we stimulate cholinergic receptors. So one of the big things that happens is you can get hypotension. So you get vasodilation, and you also get a reduced heart rate. And you put those two together, you can get a really profound hypotension. And so hypotension is one of the main things that you can see with cholinergic stimulation, and it really limits the usage. Because you get vasodilation, you can get flushing, red skin, from cholinergic stimulation. Of course, you also are going to see increased secretions, this primarily coming from stimulation of the M1 receptors. So you can get salivation, gastric secretions, intestinal secretions, and sweating. There's going to be increased GI motility. This is contractility of the smooth muscle. Because you have increased GI motility, it can go either way. So you can have it come out your end, which you'd get diarrhea, or you can have it coming out the front end, nausea, vomiting. Because the smooth muscle is contracting, you can get cramps from that, and that causes the abdominal pain. So diarrhea, nausea, vomiting, and abdominal pain. There's going to be increased tone of the detrusor muscle of the bladder, which is going to make it easier for you to urinate, but it can come to the point where if you have toxicity, the detrusor can become somewhat spasmodic, and so you can get urinary incontinence. This can be a good thing, though, if you're dealing with a patient with a neurogenic bladder or difficulty urinating. You can help them urinate using a cholinergic agonist. Of course, there's going to be contraction of the sphincter pupillae. That's going to cause meiosis. Meiosis is very, very common side effect, often though a desired effect in many of the drugs because they have ophthalmologic applications. But this is important when we're talking about organophosphate poisoning, that you know that meiosis is associated. And this is often the very first thing that you're going to see because the sphincter pupillae muscle is so sensitive to cholinergic activity. And then bronchospasm. So this is just smooth muscle existing in your bronchi, in your airway. And again, this is another very important effect of cholinergic stimulation because this can be one of the first things that can kill you. And I should also say that you can get increased secretions of your bronchi, bronchorrhea. And this is something that will kill you if you get bad enough cholinergic poisoning, because this can happen so fast and you can go into respiratory distress really quickly. If you see patients who are poisoned, and look back on, if you watch CNN when there was that sarin poisoning in Syria, you see a lot of those patients there's foam around their mouth, those victims, and that's from the bronchorrhea, and they're trying to cough that up so they can take a breath, but they can't, and this is often what kills them. So these are the cholinergic agonists we're going to talk about. There's two different types, direct acting and indirect acting. And then if you break down indirect acting, there's the reversible and irreversible. So direct acting cholinergic agonists work exactly the way they sound. They stimulate the muscarinic receptors, or nicotinic, but primarily here we're talking about muscarinic receptors. They stimulate those receptors. Indirect acting works a little bit differently. They work by blocking acetylcholinesterase, and because you block acetylcholinesterase, you'll then have more acetylcholine working at the synapse, and so you'll have more stimulation of your nicotinic and muscarinic receptors. The ones that are irreversible, there's just one of them, and that's thiofate. And basically what we mean by irreversible is that they don't spontaneously dissociate from the acetylcholinesterase. It bonds covalently, and so there's no way of recovering that acetylcholinesterase enzyme. The only way you'll be able to recover acetylcholinesterase activity is by synthesizing new enzyme. So your direct-acting cholinergic agonists, they directly stimulate cholinergic receptors. So here's 4 of them. As you can see, acetylcholine is, I guess you can call it a prototype, but it's naturally occurring. Then there's bethanechol, carbachol, and pilocarpine. Now, notice which one of these is not like the others. You can pause it and take a look at these. I put the chemical structure up here for a reason. So it's pilocarpine is different from the other 3. And so why might pilocarpine be, even though it's pharmacologically a little bit less potent, it is much more potent effectively? So this can penetrate the central nervous system because it is lipophilic. It doesn't have a charge. It is a tertiary amine. And so this can penetrate the CNS, so effectively it is much more potent. And you'll want to keep that in mind. Anytime you have a charged amine, you are a little bit less potent. You can't penetrate the CNS as you can if you have an uncharged lipophilic amine. So bethanechol lacks nicotinic actions, which is really a good thing when we're talking about cholinergic agonists, because we don't want to wipe out the autonomic nervous system. We really just want to affect these muscarinic receptors. It primarily works by stimulating the smooth musculature of the bladder and GI tract. So what receptors do they use? Muscarinic receptors, but what kind? M1. So these primarily work on M1 receptors. So it's often used for urinary retention, for instance, postoperative urinary retention, and for non-obstructive megacolon. Anytime, though, you suspect a patient has megacolon, you want to rule out obstruction. So a lot of times you'll see this in sort of like a paralytic post-operative urinary retention and megacolon, but you want to make sure that you rule out obstruction in either case. So that's bethanechol. Carbachol is very rarely used therapeutically. Usually when you see it used, it's going to be as drops, eye drops, to induce meiosis and reduce intraocular pressure. Why does this reduce intraocular pressure? Because it stimulates contraction of the muscles of the eye that will open up Schlemm's canal and allow for drainage of the aqueous. And then you have pilocarpine. Pilocarpine, remember, can penetrate the CNS. It's therefore a very potent secretagogue, but it's primarily used for the emergent treatment of acute glaucoma. Often pilocarpine will be teamed up in the medication with timolol. Timolol is a beta blocker. What timolol can do is it can reduce the production of aqueous. So you're working in two ways. You've got pilocarpine, which helps you drain the aqueous, and timolol, which reduces secretion of the aqueous. Both of those together are really going to help you reduce your intraocular pressure, so you can imagine that's very useful for treatment of acute glaucoma. Rarely pilocarpine is used for Sjogren's syndrome because it can really help you secrete saliva, and that's useful for dry mouth. The potential for toxicity is relatively high because it can get into the CNS. And so all of those awful things that can happen, a lot of those side effects can really happen if you get too much pilocarpine. And this is one of the things that if you're going to see a cholinergic agonist cause some of that really bad toxicity, pilocarpine will definitely be one of them. Your indirect cholinergic agonists, these inhibit acetylcholinesterase. So the one that I want you to pay attention to in particular here is thiostigmine, not because we use it a lot, but because it has a couple important applications. So thiostigmine, as you can see here, is a tertiary amine. It's lipophilic, therefore it can penetrate the CNS. It does, like bethanechol, stimulate bladder and intestinal smooth muscle, and it also lowers intraocular pressure and blood pressure. It can be used as an antidote for anticholinergic overdoses. So patients who, for some reason, took too much atropine, let's say that you were trying to stimulate their heart, or who overdosed on tricyclic antidepressants. Let's say a little kid gets into mommy or daddy's medication, or a suicide attempt, for instance. This can result in, the thiostigmine can result in cholinergic crisis due to accumulation of acetylcholine. This really applies to any of these drugs. They can result in cholinergic crisis if you take too much of them. You have to be very careful, though, with any of these drugs. Careful with any drug in general, right? But you have to really be careful with the drugs that can penetrate the CNS. So that's thiostigmine. Pyridostigmine and neostigmine may be used for the treatment of myasthenia gravis. So as you remember from our previous talk, myasthenia gravis is antibodies against acetylcholine receptors. So what's a way that you can get over that? Well, these antibodies are competitive inhibitors. And so by increasing the amount of substrate of acetylcholine, you can reduce the effect of those competitive inhibitors, those anti-acetylcholine receptor antibodies. So they are used for the treatment of myasthenia gravis. They stimulate bladder and intestinal smooth muscles. As you can imagine, urinary incontinence and diarrhea are going to be side effects. Neostigmine can be used as an antidote for tubocurarine. And tubocurarine is a blocker, particularly of the muscular nicotinic receptor. And that is, tubocurarine itself is really not used. It's the kind of the precursor or the prototype of some of those medications that are used very widely in anesthesia, like vecuronium and rocuronium and pancuronium. So if you have neostigmine, you can reverse the effects of that by increasing the amount of acetylcholine at the synapse. So neostigmine is used as an antidote. Edrophonium, also known as tensilon, is not used therapeutically, but it is commonly used diagnostically because it has a very, very, very short half-life, but it's at the same time very potent. It is used often for the diagnosis of myasthenia gravis. So you give a patient who has myasthenia gravis edrophonium, and that's going to rapidly increase the amount of acetylcholine they have at their synapse, and so their symptoms of myasthenia gravis should improve. They should gain more strength, but then as the edrophonium wears off, that strength will then go back down to what it was before. So edrophonium is not used as a treatment, but it is used for the diagnosis of myasthenia gravis. It too can be used as an antidote for tuberculin and for similar drugs like pancuronium, etc. And oftentimes you don't need a very long-acting antidote for those drugs because those drugs themselves are very short-acting. And then there's another, we could call it a subclass, but they're really very similar, of these medications that you will see used clinically. So I would remember these if you're taking step 2 and step 3 in particular. You're probably not going to see physostigmine or pyridostigmine on step 2 or 3, but you will see donepezil, galantamine, and ribostigmine. These are very, very commonly used. And first off, as you can see, donepezil here, it can penetrate the CNS, as can galantamine and ribostigmine, and that's a good thing because our application of these drugs is for Alzheimer's dementia. You do see them occasionally employed in Parkinson's dementia as well. They are actually first-line symptomatic treatment. And note that I say symptomatic treatment. They don't actually affect the course of the disease, but they can improve symptoms. So donepezil, galantamine, and ribostigmine. And it's hypothesized that Alzheimer's is associated with a deficiency of cholinergic activity in the CNS. So if you can get some of those cholinergic agonists into the CNS, supposedly you can improve the symptoms of Alzheimer's. It hasn't been proven that it certainly has not been proven that this slows the course of Alzheimer's. It probably doesn't. It hasn't even been proven that it improves the amount of time that it takes from diagnosis to institutionalization. But they are used as symptomatic therapy. So donepezil, galantamine, and ribostigmine. Thiofate is an irreversible indirect inhibitor of acetylcholinesterase. It's an indirect cholinergic agonist, but it is irreversible. And as you can see here, it is a salt, and this is going to form a covalent bond on the acetylcholine esterase, and so you will not be able to regenerate that acetylcholinesterase. You'll have to create new acetylcholinesterase. And so because of that, it has a very, very long duration of action. And so its therapeutic usage is somewhat limited because of that. It's also somewhat toxic. So rarely it can be used as a second-line treatment for open-angle glaucoma. You just have to be really careful with it because it's irreversible. When you do use it, though, it works for like a week. So you just give the drops and it lasts for like a week. So that's thiofate. The one thing I would know about that is that it is irreversible. So organophosphate poisoning. You may see this in the news. It happened in Syria. Bashar al-Assad poisoned his people, supposedly. And as you can see, very, very, very bad. It was also used as a terrorism agent in Japan about 20 years ago or so on the subways. And lots of people died from that. And it is also used as a pesticide for farming. Here you got a guy with a gas mask. Good, good, good. But we would like to get rid of these organophosphates. They're not good. We'd rather find something else because they're poisonous. But good to see that he is using protection there. Protection's always good. So organophosphates have two major purposes. Farming, used as pesticides. You'll hear these names thrown around: malathion, parathion, and dichlorvos. And then you'll also hear about it in chemical terrorism. These are your nerve agents like sarin and soban. There are other applications for organophosphates, I think in making plastics, manufacturing. You see that, but these are the two major implications for our purposes. The symptoms of organophosphate poisoning, there's a couple different, actually there's a few mnemonics. These are my favorite ones. So the first is sludgem, S-L-U-D-G-E-M. That's salivation and seizures, especially if they get into the CNS. Lacrimation, tears. Urination, defecation, primarily your diarrhea, incontinence of stool. GI motility, which can cause abdominal pain. Emesis and meiosis, sludgem. The other one is muddles. Meiosis, urination, defecation or diarrhea, diaphoresis, lacrimation, emesis, and salivation or seizures. Another important one that doesn't come up in here in these mnemonics is respiratory distress due to bronchospasm and bronchorrhea. This is an important one because this is often what kills these patients. The other thing that's really, really acutely dangerous is seizures. You think we're worried about salivation and diarrhea acutely? No. We're not really worried about that. What we are worried about in these patients, what kills them, once that come in with acute organophosphate poisoning, we're worried about respiratory distress, bronchospasm, seizures. Those things will kill you. Diagnosis, it's really just clinical. There's no lab tests to run. If you've got a farmer coming in with unusual symptoms and you ask if he's exposed to any chemicals and he says, yes, I use pesticides, well, then that really helps if you put that into context with some of the symptoms that he's coming in with. If you have a large-scale attack where you have lots of people coming in with similar symptoms, you have to start thinking of possibly terrorism. God forbid, but it does happen. It happened in Japan only 20-some years ago. So this is a potential agent for terrorism. The treatment for organophosphate poisoning, really, it's several things that you're going to do. If you're taking step 2 or step 3, you need to know those several things. If you're taking step 1, the one thing you need to know is pralidoxime. Pralidoxime is the antidote for these organophosphates. It's really the antidote for any cholinergic agonist. But pralidoxime is your antidote, and it's given parenterally. It can be either given IV or IM. If you're taking step 2 or 3, or for clinical purposes, you need to know the other things that we do to treat these patients. Step 2 and 3 are more clinically oriented, and so you need to know sort of your holistic care. So in addition to giving pralidoxime, which is going to help you regenerate your acetylcholinesterase a little bit more quickly, atropine is going to help you more acutely. So atropine will block off those muscarinic receptors. So think about what our problem here is. We have organophosphates coming in and blocking off acetylcholine esterase. And so you're accumulating acetylcholine and you're stimulating all those receptors. There are 2 ways we can get around that. We can treat these people. We can help them regenerate their acetylcholine esterase by pulling the organophosphate off the acetylcholine esterase, helping that acetylcholine esterase work again. Or we can work the other way and we can block off those muscarinic receptors. And so it's going to be pralidoxime that helps you regenerate your acetylcholine esterase, and it's going to be atropine that inhibits those muscarinic and nicotinic receptors working against acetylcholine. And you want to give both, because pralidoxime will take some time to work. Atropine works more quickly, and it can help reverse some of those symptoms of organophosphate poisoning, helps reverse those cholinergic symptoms. So you'll co-administer pralidoxime with atropine. You also want to give benzodiazepines because most of these will penetrate the CNS, can cause seizures. So giving something like diazepam as seizure prophylaxis, very important. Maintain airway control because of the bronchorrhea and bronchospasm. You may even need to intubate these patients depending on how their lungs sound and if they're in respiratory distress or not. You want continuous cardiac monitoring. Remember, lots of M2 receptors. If those are stimulated, it can really slow the heart down. These patients can go into cardiogenic shock. You want to remove all clothing. This stuff seeps into clothing. As it gets into clothing, it basically serves as a reservoir, and these patients will continue to absorb these agents. So you want to remove their clothing so that they don't continue to, you want to get rid of that reservoir of organophosphates. Okay, so that is your treatment. If you're taking step 1, please remember pralidoxime. Pralidoxime is the antidote for organophosphate poisoning. The classic vignette, you have a farmer coming in with meiosis, throwing up, losing continence of urine and stool. If you listen to him on physical examination, you may hear some wheezing because of the bronchospasm. The bronchorrhea can cause a mild pulmonary edema. And when this gets really severe, you can start having seizures. So this is pralidoxime, and pralidoxime is the antidote for organophosphate poisoning. Now, this is how pralidoxime works. So you have the organophosphate, which bonds covalently to the serine residue, this oxygen on the serine residue of acetylcholine esterase. And you have this covalent bond, you need to break it. And what you have is a hydroxylamine group on the pralidoxime. And the oxygen on the hydroxylamine group is very nucleophilic. And well, what is a big nucleus? Well, it's that phosphate sitting on the organophosphate, big nucleus. And how many bonds does phosphate like to form? It likes to form 5 bonds. So what happens is that oxygen on the hydroxylamine group will donate electrons over to phosphate and or to phosphorus, I should say. And when those electrons go over to the phosphorus atom, it's going to push electrons away from the bonds that were on the phosphorus with that oxygen, that phosphorus oxygen bond. It's going to push those electrons towards the serine. And so it breaks that phosphorus oxygen bond that was holding the organophosphate on acetylcholine esterase. And so essentially what you're doing is you're forming a bond between pralidoxime and the organophosphate and breaking a bond between your organophosphate and the acetylcholine esterase, and then you pull that organophosphate off and you've now regenerated an active acetylcholine esterase. And this is really good. The only problem is it doesn't help you for non-organophosphate cholinergic toxicity. And so for that, you're going to need to use something else, namely atropine. So just to recap, the general application of cholinergic agonists is very importantly to reduce intraocular pressure in glaucoma, to induce meiosis for ophthalmologic procedures. It can also stimulate the bladder and intestine. It can be used to diagnose and treat myasthenia gravis, and they're also used for the symptomatic therapy of Alzheimer's. The effects are hypotension because they reduce the heart rate and increase vasodilation. They can induce bronchospasm, urinary incontinence, diarrhea, abdominal pain, sweating, meiosis. Note that I didn't put side effects because sometimes these effects are desired, particularly meiosis may be desired. Urinary incontinence may be desired if you're retaining urine. So these are just general effects. Some specific cholinergic agonists include bethanochol, used for urinary retention and megacolon. Pilocarpine, often teamed up with timolol, but pilocarpine is used itself. It can reduce intraocular pressure in open angle and narrow angle glaucoma. Physostigmine, remember physostigmine penetrates the CNS. It is used for urinary retention and megacolon to reduce intraocular pressure, and because of its ability to penetrate the CNS, can be used as a very potent antidote for atropine and tricyclic antidepressant overdose. Neostigmine is used in the treatment of myasthenia gravis. It's also an antidote for tubercularine. Edrophonium is used for the diagnosis of myasthenia gravis because of its very short half-life, and it can also be used as an antidote for tubercularine. Donepezil, galantamine, and rivastigmine, very important medications in the treatment of Alzheimer's, although it only treats the symptoms, it does not treat the course of the disease. Pralidoxime is the antidote for organophosphate poisoning. Because pralidoxime can only work by plucking a phosphate off of a serine residue, it doesn't work for non-organophosphate cholinergic poisonings. That is where we use atropine. So atropine is a general antidote for cholinergic toxicity, and atropine works by inhibiting those acetylcholine receptors. And so that would be used if you have a poisoning from something like, say, physostigmine, for instance. You would use atropine as your antidote. If you have any questions, write me a note below. Otherwise, I will see you next time.